By request of the meeting organizer, this meeting is being recorded.
My name is Michael Hager. I'm the Manager of Technical Assistance and Dissemination at the National Quality Center, and we are pleased to have you on our March 31st office hours call addressing the comprehensive health needs of African-American and Latino women. Before we start, one of the things that's always really helpful is just for folks to kind of identify themselves in the chat room. It helps us to make connections as participants in the call to see other folks in our region, and also maybe just for contact later. After today's call, I'll be circulating the recording of today's webinar in addition to some of the chat transcript and participant list information. So you can cross-reference that and know whom to contact after the call to reach out and say hello and get some advice on how to build your program. Welcome especially to Dolores and Allison, who are going to be helping to facilitate the call. I'll go ahead and put my stuff in the chat room too. Michael Hager, NQC, NY, and end disparities leader. Okay, and I see a number of folks entering their info in the chat room. So for those of you who are new to a call like this or joining our recording for the first time, the End Disparities Learning Exchange is a 9-month initiative that promotes the application of learning around HIV health disparities for 4 subpopulations. Although our learning is applicable to other subpopulations as well, there are many cross-cutting themes, as you'll hear if you go back through our previous recordings or if you continue to join us in the future. The purpose is to create a community of learners across RYMY HIV/AIDS program recipients and consumers to make sure that we can all advance the topic of health equity together as far as HIV health outcomes are concerned. If you haven't had a chance to check out the End Disparities Exchange promotional video, we invite you to do so. You can find it on our YouTube channel or on the End Disparities Exchange website. It's just 3 minutes long, and it's a great way to galvanize support around these important initiatives and, you know, the topic of health equity as far as HIV health outcomes is concerned. So please take a look and share with your friends and colleagues in your service center or with other consumers that you may know. Our office hours occur they do occur on Friday at 1 p.m. It's not every Friday. It's a variable schedule. So we encourage you to check our website or to check our Facebook or our newsletters. We always keep everyone up to date in terms of when we have our office hours. As you know, no registration is ever required. It's open to anybody, RYMY HIV/AIDS program recipient staff, consumers, or just community members who are interested in learning more about HIV health disparities and what they can do to personally make an effort against them. We want to encourage as much open-ended dialogue as possible, and really you are the important participants in today's call because we want to make sure that we cover your questions and concerns and also provide some important tips and tricks to serving African-American and Latina women across our big country on today's call. So please make sure that you ask questions as they occur to you, we are ready to answer them. And because we had a little bit of noise on the line, I went ahead and muted all the lines. You'll notice that there's a little orange microphone next to your name. To unmute your line, all you need to do is click that. Allison and Dolores, I went ahead and unmuted you already. It's just so that we can have our conversation going. For those of you who are muted, again, unmute your line to ask your question or enter your question in the chat room. If we don't have enough conversation, I'm going to go ahead and unmute the lines, and hopefully we won't have too much distraction. So our topic today is comprehensive health needs of African-American and Latina women. We know that these are 2 very large, diverse groups of women, and our country is massive, and there are a lot of different issues at play for us to keep in mind. And to help us facilitate today's discussion, I have Dolores Dockery on the line. She is a friend and colleague. She works with Hyacinth Foundation in New Jersey, and also with a number of other initiatives nationally and internationally. She's been involved in helping us to shape the work of HIV quality management for many, many years. And so she's a wonderful resource to have on today's call to help us think through comprehensive health needs of African-American and Latina women. Also, to help facilitate, I have Allison Bowman from Boston University School of Public Health. And in her role there, she is working with women and community health workers to build programs that are helping women address the needs of other women. And so Allison has a really wonderful and rich background to help us think through what it takes to build leaders within communities and to help to drive improvement in healthcare as it will relate to HIV health outcomes. So, you know, at this point, I'd just like to introduce Dolores and Allison to see how we can get today's conversation going with the women on the line. And I'll start a chat board just to take some notes while everyone's talking.
Great. Thanks, Michael. Thanks very much. This is Dolores, Doctor, and I think I will start with Allison because Allison will be able to discuss from the standpoint of community health workers and to really help us to discuss and reflect on how community can serve the healthcare needs of people living with HIV. So, Allison, would you like to just go ahead and tell us a little bit more about yourself and to begin the discussion?
Sure, I'd be happy to. Thanks to Michael and his team for inviting me back. I really had a good time with you guys previously, and I'm looking forward to hearing the discussion and conversation today. So I work at the Boston University School of Public Health, and right now I'm working on a project that aims to improve access to HIV care, particularly for women of color, including African-American and Latina women especially, in increasing their access to HIV care through the use of community health workers. The reason that we are engaged in this project is because community health workers have a lot to offer to the HIV care team and to the communities that HIV care settings are serving. In particular, they bring unique life experiences with them as members of the community, and they also really function as a bridge between the community that the healthcare setting is intending and wishes to serve and the healthcare setting, the community itself, which is key to, to having good outcomes in the clinic and to clients and patients having good outcomes with, all the different areas in their life. Community health workers specifically, we want them to be integrated as part of the care team, and we also are training them to really address needs that are unmet or can be unmet by the healthcare setting, such as housing, transportation, child care needs, other sorts of economic and social needs that really can impact health outcomes and impact the ability for these patients to come into care and to be retained in care. So it's an exciting project. We are just, like I said, towards the beginning. We're in the first 6 months of this 3-year initiative. So we're really excited to see how it goes and the things that we learn from this process.
Thank you, Allison. And the other thing I want to, first, I really support the whole idea of community health workers. It is pretty much a buzzword now for HRSA and for many states. I think one concern I have and what I'd like you to expand on is the training needs of these community health workers. I know where I am in New Jersey, we're still waiting on a curriculum to train community health workers, although their roles are funded and they're installed in many agencies. I am concerned about what are the training needs. So do you have a curriculum that you have developed? Is it available? And tell us a little bit more about the training that the community health workers in your project have to go through.
Sure, I'd be happy to, and that's an excellent question. So one of the key products of this initiative is to develop what we hope might become a sort of national standard for training community health workers, specifically in HIV care. And so what we've done so far is designed a training that is going to be about 80 hours in length total. We will be training community health workers who are working as part of this initiative for 40 hours in person, and that's happening this fall. And then we will be providing the other 40 hours of training through a combination of online training and some in-person training as well. So we have in the training, which we've developed through an exhaustive look at what states require for their own training and other training experiences that we've had here where I work with peers. So we have training topics that are for community health workers in general, such as motivational interviewing, such as documentation, such as working as part of a team, practicing safety and communicating effectively, issues around privacy, working in the healthcare setting and with clients. And then we also have, as part of the training, things that we want specifically to include for community health workers working in HIV care. So, you know, for example, the basics of HIV and more specific information about the HIV life cycle, medication for HIV, HIV and other comorbidities, and mental health and managing stigma and disclosure, these sorts of things. We will be publishing our training curriculum. That probably will happen sometime in the fall, maybe the late fall. I can certainly let everyone know about that. It will be on our website when we do publish it, and I will type in the link or the address to our project website in the chat room so everyone can have it. I also want to point out that in this initiative, we consider it to be extremely important to provide people that supervise community health workers with training as well. I think from my experience in talking with community health workers, a lot of their challenges come from differences in supervision and maybe some challenges with the skills that their supervisors have because they tend to have unique roles in the healthcare team. So we are also developing a 2 to 3 day training for supervisors who supervise community health workers in HIV.
Wow, that is key. Thank you. So we have some questions coming up in the chat box. I'm going to ask them now before I open it up to everybody because there's just one other presenter who is not on the phone with us but who sent in their contribution, and I will read their contribution before we open up for questions. So one of the things I want to ask you, Allison, is kind of who are the best persons, who are you looking for, to take on the role of a community health worker? And somebody was asking, is there also a job description? So I'll start with who are the best candidates for this job, a community health worker? Who are you thinking about? And then we'll go into kind of what does that job description entail. And I think some of it was kind of alluded to in your discussion around curriculum. But if you could just answer those two questions for me.
Sure, I'll certainly the best that I can. I think these are really interesting questions, and part of the reason for that is that the discussion and the conversation around these things is still sort of ongoing. I'd also like to sort of, I guess, make another plug that another one of the products that we're developing as part of this initiative is an implementation guide for clinical settings who are interested in either developing a program in their healthcare setting for using a community health worker, or for settings that already have
analysis and treatment for your allergies.
I apologize for that. Hold on just a moment.
From 8 a.m. to 5 p.m.
I just need to find where that's coming from.
Or to make an appointment, call 98.
There we go. All set.
Okay. So, so we are, as part of this initiative, writing, and we will be publishing an implementation guide for sites and clinical settings to use with sort of from soup to nuts around community health worker programs. And a whole section of this guide is devoted to recruiting and hiring community health workers. I have the guide up, and I can give you some of the things that it talks about. And again, this will probably be available sometime in the late fall on our website. So there are some sort of consensus around the qualities that community health workers should have in order to be successful in the job. And I also would refer people to some work that's being done at the national level around the role of community health workers, the skills that they should have, and the qualities that they should have as individuals. And this is coming out of something called the Core Consensus for Community Health Workers Project, or the C3 project. And I can put a link up to some of their reports as well. But in general, you know, effective community health workers have really a desire to help individuals in their community. They are part of the community. They live there. They plan to stay there. Often they have already established many connections to different agencies, different resources in the community. They may even have a reputation as a leader in that community. They also tend to already have a good ability to communicate with people, and that is, you know, enhanced and strengthened through training. I think generally they're very effective if they have kind of a more outgoing personality and really enjoy working with other people. They also, I think, really good ones, and again, this is strengthened by training, they have this ability to build rapport and build effective relationships, even across different characteristics. Because, you know, unfortunately, it's not always possible for an individual healthcare agency to have community health workers that really reflect the intersectionality of the people that they serve. So, for example, many community health workers that I've met and worked with are women of color, some of them living with HIV, some of them not. And they work not just with women of color in their healthcare settings. They work with, you know, young people, older people, people of different race ethnicities, and people of different genders, and also, you know, social histories. Language capacity is also a very often seen qualification or capacity for community health workers. In terms of job descriptions, we will be having some example job descriptions in the implementation guide. And job descriptions, I think, are key. One of the interesting things that we've learned through our process so far is that sometimes it is actually difficult dealing with the human resources department in an organization to actually have the job description for a community health worker approved. It might be a new role to the organization, or they just might not quite understand, you know, what the job description is showing. It can also be difficult if the agency is really interested in hiring someone as a community health worker that has life experience, for example, with incarceration, because background checks can be something that you'll encounter. So working with the Human Resources Department can be early on can be really useful for agencies.
Excellent. Thank you. You did a good job of answering those questions. And again, I'm seeing some other questions in the chat box. I think I think we answered this, but I want to make sure. Somebody is asking, so how do you define a community health worker?
Yes. So we use a definition that's from the American Public Health Association. And I can share that with you. There are different definitions because there's still sort of this building consensus around the definition of community health workers, as you said, and who can be a community health worker. So the definition that we've adopted is, I can just sort of read it to you. It's not very long. It says, a community health worker is a frontline public health worker who is a trusted member of and or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison or link or intermediary or bridge between the health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. A community health worker also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities, such as outreach, community education, informal counseling, social support, and advocacy.
Great. That's a long one. I'm wondering, Allison, if you could just tell me one more time where that came from. That way I'll put it in the notes and people can get the full definition later.
So that comes from the American Public Health Association. And they have an actual section around community health workers. I can put the link in the chat box right now.
Wonderful, and a great group, too. Thank you so much.
Yes.
Excellent. Thank you so much. And we'll have a lot more questions for you. But what I'm going to do at this time is to read the contribution that comes from Julia Gaynor. I hope I'm saying that right.
Julia Gaynor from Duke, yes.
Julia Gaynor from Duke University in North Carolina. And she regrets she couldn't join us today, but she definitely wanted to tell us a little bit about her program and what happens at her site. So she says, our site has met once a month for many years now, together with representatives from high-risk OBGYN, adult infectious disease provider, pediatric infectious disease provider, social worker, and nurses to review all HIV-positive pregnant women that our outreach social workers are aware of. We discussed the estimated due date, where the mom is receiving care, what her CD4 and viral loads are, what medication she's on, any resistance she might have, and the next appointment with the ID and OBGYN, whether the fetus is high or normal risk. If high risk, what triple combo we plan to use, as well as any social factors. So during this, it allows us to make sure that our HIV-positive women are in care and can better anticipate any potential challenge. We also review the exposed newborn at the same visit, their HIV RNA testing results. For exposed newborn who receive triple therapy, we continue HIV RNA testing through 6 months of age. Collectively as a group, we made the decision to recommend that all HIV-positive pregnant women be given IV AZT at partum, in spite of changes in the recommendations, as we felt that if the OB on call had to make the decision that some infants who were at higher risk would be missed. missed. Also, someone from the pediatric infectious disease clinic meet at least once during perinatal visit with the pregnant women when they go to their OBGYN visit to let them know what to expect once they deliver. We cover what to expect during and after delivery, along with the fact that they will need to give their baby medication for a period of time after birth and return 3 to 4 times over the coming months to have the baby tested for HIV. We review where they will need to come with their baby and the option to come into the Raleigh clinic. In the last calendar year of the HIV-positive pregnant women our site followed, 59% were African-American and 17% was Latina. The remaining were 21% Caucasian and 3% Asian. Latina ethnicity was counted as a race, though we recognize that this is not a race. An issue that we have had is where mothers have not told the father of the baby about their HIV status. Sometimes the father of the baby was not in the picture at all. It is the policy that if the father of the baby is involved in the newborn care, that we must be able to disclose before leaving the hospital. This policy was put in place after having to think about what it is we must do to make sure this mother and newborn are safe and remain in care, and confrontation by the hospital nurse who felt when a father of the baby come to see the baby but not know about the woman's HIV status. I think this might be a point for us to discuss as we continue. Anyway, I'm going to continue reading her contribution. Pediatric and/or adult ID will assist a woman if needed, and it is documented in the medical record that this has occurred. This is a topic unto itself and may or may not be the right place to talk about it on this webinar. Transportation is also a big issue. Many of our clients do not have car but live in rural areas and do not have the money to pay for gas and parking to come to the clinic. The transportation system down in North Carolina is poor, even for clients who live in the city. Buses are infrequent and you have to go to the terminal to access another bus as they do not cross. Many of our clients come from further away. If clients come on the Medicaid van, they are here all day and may need to ask someone to pick up their children from school bus stops or ask someone to drive them to clinic. Case managers, including outreach social workers, work to provide transportation assistance to clients. Appointments for mom and exposed newborns are scheduled on the same day whenever possible. This might make the day longer though. Our clinic is a pediatric clinic. We share space with our pediatric specialists that see patients on other days. There is no sign identifying the clinic as an infectious disease or a HIV clinic. Our clinic started seeing clients in Raleigh 1 full day and 2 half days every month. The location is closer for many clients, easily accessible on the bus line, parking is free, and the clinic is across the street from Wake County Health Department, where some of our mothers receive their care. Our clients are by and large impoverished and need help in accessing the various programs available to them and their newborn child. Social workers work with the client at each visit to identify and address any needs, such as WIC, Welcome Baby, the diaper bank, etc. Diapers are provided to carry over clients until they are able to access other programs. A welcome quilt and cap and other supplies are provided. Quilts and caps are handmade by individuals who donate these to the clinic every year. New is that we are hearing from Latinos in the community that they are feeling very scared that they will be stopped when driving, found to have no driver's license. Because in North Carolina, you cannot get a driver's license without a valid documentation showing you're allowed to be in the U.S. So they are afraid that they will be arrested and deported. We are hearing that people want to stay closer to home to reduce this risk. We haven't started to see much of the effect yet of this fright within the Latino community yet, but we hear about it at many meetings. It will surely affect care of all our Latinos. I hope I was able to read that clearly enough so that you hear it, but I thought it was very detailed and really addressed some of the challenges this particular site is encountering. I want to be able to open up the discussion, and I'm going to ask Michael to open the line. First, for any reaction from the contribution that I've read, and then we will ask Allison any additional questions around community health workers. So any reaction from the contribution that I've read?
Everyone's line is unmuted, and if there are any, background noises on hold music, I'll go ahead and mute that specific line. But everyone should feel free now to be able to share what their thoughts are and what their feelings are regarding Julieta's contribution down in North Carolina. So I see some reaction about, the driver's license issue and the issue or the fear that people have in terms of being pulled over. I think that's, really scary. And I've heard that being a challenge in many parts of our country, that it'll remain to be seen, how we can work with that. I don't know if anyone has any suggestions or solutions that they've heard of in terms of helping folks of Latin American backgrounds feel better about this possibility.
Your lines are all open, so we welcome your opinion at this point. So, Allison noted that she cannot believe that in North Carolina you can't get a driver's license without the documentation. And I must say that it's not only North Carolina, but in many states, they ask you for different points of identification. And often these points of identification are all related to whether or not you are able to legally live in the U.S. So I think it is a problem across different states.
What was the pen?
Go ahead. Hello. Anybody else? Yes,
Doris,
go ahead.
Michael, this is Debbie, colleagues that are on the phone. But in the panhandle of Florida, also in the Virgin Islands, we're using mobile units in order to go out so that individuals do not have to drive to receive care, and that mobile units that have all kinds of health care so that individuals could be seen any disease and feel comfortable because the unit is not known as an HIV care kind of unit. And that seems to help alleviate counts related to the ability.
Debbie, you're breaking up just a little bit. I'm very sorry. We're catching maybe every third word.
Is that any better?
A little bit better. We heard that mobile units are a solution to helping Latin American groups feel more secure about accessing health care. And I'm wondering I think that's all I heard, that you use in the Panhandle, yes.
Right. And we're doing that in the Virgin Islands as well as an opportunity. Issues throughout, our friends and throughout. Thing that I can mention. Can you hear me still?
it's really challenging. I'm very sorry.
Okay, that's all right. How about now?
Yes, I can hear much better.
Okay, I'm at an airport, so I'm outside now. What the other thing I want to mention is that when I was living for a long time in Tennessee, in the northeast pocket of northeast Tennessee, where Virginia, North Carolina, and Tennessee all meet up, a very rural area, Appalachia for sure. Many people don't have cars at all, and there's a big a need and a big family of individuals who work in either as domestics or in the migrant fields. And we developed, while I was there, a Head Start program. And that Head Start program began to be the satellite for all kinds of care that were delivered to families that were working in the field. So the Head Start program actually functioned more than just a preschool. It functioned as a family support network for health and wellness for all members of the family.
Wow, that is phenomenal. So I hear from you that you use mobile units to provide care in the community, and that reduces some of the barriers that the community experience around transportation. Also, you talked about the Head Start program and that it is more than just, early education program, but it really does provide family support to the community. We missed some of what you said as it relates to how mobile van reduces barriers in the community, and I don't know if you want to take the opportunity to kind of repeat that.
Yes, we'll see. Hopefully you can hear me. The mobile units are not seen as specific to any type of disease process, so the stigma of utilizing the vans is not as high as one would think, and it's seen as it's used for health for individuals who need mental health treatment, to get them to and from appointments, or to administer monthly medication for those individuals who we know are needing antipsychotics. So it serves as a multi-purpose van and is seen by community members, many of our minority patients, as being a friend and a place of learning and a safe haven, if you will.
Excellent. So who are some of the workers that you have on your mobile van?
That's a great question, Doris. In fact, in one of the vans that I'm familiar with up here in, actually it's out of Gainesville, Florida, one of our lead physicians, who's a primary care expert, also LGBTQ friendly, he has students and nurses and other community health individuals on the mobile unit, and so there's a teaching and learning that's going on with that van as it moves from location to different locations.
Excellent. Thank you so very much. Thank you. Any questions? So this conversation has been rich in looking at not only some of the services that are being provided to women, African-American and Latino women, and women in general, but kind of some of the issues that arise. We see the benefit of community health workers, and these can be peers, and peers in the broadest sense of the word. They might be HIV positive, they might not be. They might only reflect the population they're serving. So it's great. The thing is, get people who are linked to the community, who understand the community, and who want to work with the community to help to improve our health outcome and to continuously link people who require health services to the health system. That's excellent. We hear about some other barriers around transportation and how that's being addressed, probably using mobile unit. And maybe there are a host of other things that can be done. If there is something being done where you are, please share it with us, because this is what we need to understand. How can we address issues of transportation? So I'm going to stop there and just ask you, where you are, how are issues of transportation being addressed?
And to piggyback on that, it'll be really great to hear, to Allison's point in the chat room, folks who are more urban and folks who are more rural, both, because as we know, there's a lot of differences between urban and rural environments. We want to make sure that we're giving a lot of airtime to both situations.
Hi, guys. Can you hear me?
Hey,
yes.
Sasha.
Hey, how's it going? I'll speak to both urban and rural here in Houston, Texas. In our urban area, our EMA, the Houston metropolitan area, we actually assist our clients with bus vouchers. We allow them bus vouchers for, I believe, a 6-month time period, which allows them to take care of their primary care visits, maybe their case management visits. They may come in just for a bus voucher and not necessarily see a case manager. However, we have some supporting or suburban areas which don't really have metro buses or things like that. So those areas, we give out gas vouchers or gas cards. And so that's how we help our communities with transportation here.
Excellent. What are some of the other challenges that your clients have in that area, and kind of tell us how you address them?
Well, some of the challenges are some that, for instance, in our Fort Bend area, you'll have a client coming in saying, I need a gas voucher or a gas card, and you're curious, at least from the provider's perspective, is you were able to get to the clinic for the gas card, but you can't get to the clinic for your primary care visit. So, there's sort of a little credibility issue there, but, we still want them in for the visit. So we want to make sure that they're using their vouchers or gas cards for the reasons that they're receiving them. So it's definitely a trust issue. We're basing it off of self-declaration. We want to make sure that we aren't supporting risky behaviors, in a sense. So but that's hard to assess. You can't follow our clients around. The Houston area, as far as the metropolitan area, is very large. So, again, word of mouth, it could take a person a couple of buses just to get to certain areas of town, which is pretty daunting. You can ride some of our rail lines, and you might have to hop on a few different trains just to get where you're going. And the challenges that creates for a person who's already living with HIV or AIDS, it's, just another hurdle they have to jump through. So we try and make that as easy as possible. Now, with our youth, we have case managers. Again, they really shouldn't be doing this, but they're accustomed to holding the youth's hands. They are driving them to their appointments themselves. We don't advocate for that because we're trying to acclimate them to the adult care system and trying to get them to be more independent. But again, they're accustomed to the hand-holding, they're accustomed to taking them to their appointments, and really just sort of cradling them. So, you know, we have some issues that we grapple with there.
Thanks.
Sure.
So, Christine noted big cities in California are paying for Uber and Lyft, which can be a way to prove that clients was dropped off at the medical office, food bank, etc. Do you want to add to that comment, Christine? Your line is open. You can go right ahead.
I see that Gina Grant has made a private comment to me in the chat room as well, asking if anyone's used Ubers. I don't know, Gina, if you've tried this in your area or if you've thought about this in your area.
Hello, everybody.
Hi, Gina.
Hi, Gina.
No, I haven't actually used Uber as a means of getting patients to the clinic, but sometimes to me, it seems a little easier because if they have to take 3 buses, and I recently had to use Uber, and I saw that they had like a business side of it, like if it was for business. So I didn't look any further into it, but I just was wondering if any other sites were using that, and how has it been working for them?
Wow. Thank you. So, Christine, I see your comment where you're in a noisy place, and I truly understand. So, Allison, you made a comment around advocacy, and as a policy person, the whole idea of advocating for change is something that's really important, and I would like you to just expand on your comment.
Okay. Well, I'm very interested in public policy as well, and so I'm always happy to talk about it, and I think it's really an interesting thing to think about. Although the benefits of advocacy sometimes don't happen for, sometimes decades. But one of the roles of community health workers that's emerged in this core consensus project that I was talking about earlier is advocacy and the sort of role of helping not only individuals develop their own capacity for self-care and for sort of managing their own lives and the things that come up in their lives, but also developing the capacity of the entire community, which can be reflected in the community's ability to organize and to advocate for improvements that I think do have an impact on a community's ability to access healthcare services and to engage with the healthcare system, at a really, really good level. And I was wondering if anyone had experience with this. It's, to me, kind of might be seen as an unusual thing for a healthcare setting to engage with, but I think it could be very important.
Awesome question. Does anyone have experience with that? I'm so curious.
Hello?
Hi.
Yes.
I don't know if I will be answering the question correctly, but I just wanted to add that in my area, I'm in Miami, most of the time, it's still a big, huge stigma associated with HIV. And when things we have events, we have things go on in the community, but I personally on Saturdays, Fridays, Sundays, the weekends, you know, book out, office time. And people come and they have events, and as big as Miami is, and with the numbers the way they are in Miami and Broward, we had literally like 6 people show up to an event.
Wow.
And I think it was so embarrassing. And I really told the organizers, like, really, I haven't learned, you coming from Washington trying to do something in Miami, and you didn't, like, talk with anyone here because you're not, number one, you don't put HIV and stuff. You know, you can't. You have to, like, kind of trick the people and just say it's health, but don't put, you know, if you put that, that's automatically to some people, they're not going to show up. So that's a big issue in my area, and it takes a community to try to help. I'm kind of like I'm a peer educator, patient advocate, all of that stuff. So within my role, I kind of like let the clients know what's going on, the benefits, and I kind of do a lot of things with the clients, but they still don't want to come if they feel stigmatized and stuff like that, you know, but I'm just at a place where I'm okay. You know, I don't care. I'm just to the point where I don't care anymore. I'm going to show up, I'm going to try to learn what I can learn, and I'm going to try to bring it back to the people who need it. But we have to remember everyone's not there, and it takes a time for them to get there. So that stigma is very alive and present, and I think that's going to always be an issue when we're trying to help people out in the community. That's just my point of view, my experience. I'm sorry. So that's what I had to say.
Great, and that is true. And I think one key thing that you said is that, you know, we really, in order to reach the community, we really need to understand the community, because we might come in with great ideas, but each community reacts differently, and I am very, very pleased that you made that contribution, because it's key. I think it also supports the work of, like, community health workers, because they come from the community and they really can respond well to the community that they are themselves a part of. I wanted to just briefly step back to advocacy, because a lot of us are comfortable to advocate at the national level, especially, you know, like joining AIDS Watch or doing something like that. I don't think a lot of us really feel comfortable advocating at the local level. The local level that can address issues such as public transportation in the city we live in, or even the availability of employment, or the availability of housing. And maybe this is where we're looking at the intersection of other social issues that impact our healthcare access. And I think that maybe that it's at that level we need to explore whether or not we can do more advocacy. I don't think a lot is done around that. It could be because we are all so siloed that even if there are groups that are advocating for employment and housing, we are probably not even a part of those groups.
Hello?
Go ahead.
I know you guys going to get tired of me.
Never, never.
Get tired of me. But even in that, we, you know, okay, so Miami, we have a partnership board who has meetings, and we have meetings with all the case managers. I'm involved in a group, which is the Care and Treatment Committee in my local area, and what we do is we look at the policies, and we look at different things that go on in the county. Like if the clients complain, oh, this agency don't have enough bus passes, they run out by the third day, can we do anything about that? This particular group, we take that to the mayor who, you know, it's like the people who disperse the money, we work with those people. So we make a vote, it goes to this person, it goes to that person, and then changes happen. But even within that meeting, the people don't show up. We have a housing meeting because housing is needed, the Hopwell funds, okay, they're having one next week. Let me see how many people show up. You understand? So it's still, but my thing is, don't complain to me if you don't want to do something about it, because two people can't make it change. They have to see our faces. Like back in the days when ACT UP was out and you saw all of the people marching for meds and all of that, I don't see that happening as much. You know, I don't see that. But we're gonna have an AIDS walk coming up in April. So I think I'm gonna go and I'm gonna see how many people show up for that, and then I'll tell y'all about it. You know, but I'm just saying, it's like I'm a person living with HIV, but I'm also in my community, and I try to get the kids. So my thing is, I'm in pediatrics. I'm trying to get the kids to get out of their way. I'm trying to get the kids to listen, it's okay. I'm trying to get the kids to, okay, you have to do a little something sometimes, maybe walk, maybe this, you know, participate, but it's very difficult. It is very difficult to get the community involved, and my thing is it's like they're making decisions without us showing up because we're not showing up.
Let me ask you this, Gina. This is Tasha from Houston again.
Hi, Tasha.
Hi. How's it going?
I'm doing great.
I appreciate your zeal and your energy. You know, I could tell you're there. I know you probably sense some frustration because you wish everyone was in the same place that you are with being an activist and an advocate at the same time. But are you Part B or Part A?
I have no idea. Don't beat me. I don't know the lingo. I'm just working. Okay. I know I work over in I don't know if I'm Part A, Part B, Part C, Part D. Okay. I know all of those things are important, but right now I don't know.
That's okay. That's okay. The reason I'm asking, yes. I'm relatively new to HIV and the AIDS industry myself, and I work within Part A here in Houston, and okay. I work on the care side, and here's some of the things that I grapple with. I yes. oversee and I lead our case management meetings, and so I'm working directly with our frontline staff. I oversee the training, cultural competency, intimate partner violence for case management staff. So I don't deal directly with our providers as far as the medical care, but so I yes. touch a certain group of people. That's how yes. it's sort of siloed or compartmentalized, I should say, in Houston Part A. Now, okay. there's another whole group. My Part A group, we don't touch the prevention. So there's another group that handles that arm of it, and that can be challenging because we know that there's no true way to separate it, but yes, we have to with the way we're funded, if that makes any sense, you know. So yes, it's sort yes. of frustrating because the people in our clinics, they can't separate it. But from a funding perspective, they have to when working with me. We can only deal with care. Now, we collaborate with the city of Houston. See, I'm Harris County, and okay. we handle certain aspects, and we fund certain things. And if I'm not mistaken, just to take it back to the transportation side, City of Houston, they have an Uber account. So they're That's able awesome. To set up that Uber account, have a PO, $5,000 to $10,000. They're able to track that account. So they're ahead of us in that regard, where they can see where the money's going, see where that client's going. And so we're a few steps back, and we're aware of it, you know. But we're thinking ahead. It takes a little bit more time with the county. So I definitely hear where you are, you know, and where a lot of people have talked about on the phone, like being in Tennessee and being in some other places, and this is how they do it. It seems to me you guys are doing sort of an amalgamation of things where you have different groups going to different meetings. I mean, we have our groups separated by persons who are recently released from the prison and jail systems, you know. So we have groups segregated in that manner because, you know, that's a specialized group, you know, who need their own separate sort of targeting systems, you know, especially if they've been in jail for 5 to 10 years, they have to reacclimate not only with HIV and AIDS medication, but just to the world in general. So, you know, it sounds like, you know, maybe if you guys were to structure things a little differently and have more subcommittees as opposed
they do have a lot of different ones. I'm just on that particular one because for my position I have to be involved with something community, and I also go to different meetings also to keep involved, and then what I learn at those meetings I bring back to the clients that I meet with in the clinic. Yes, ma'am. Yes, ma'am. Yeah. And then I also have to bring it back to my supervisor and let her know what's going on. Even though she already knows, she knows what's going on. But I have to come back and tell her, you know, this is going on and this is going on and this is, you know. So, but it is a job in working with HIV, the population. I work with the moms who also HIV-positive moms. I do partner testing in the clinic I work in. I'm coming from outreach. I started off in outreach where I was doing testing and counseling. I have worked in the jails. I have worked at the domestic violence shelter, all doing HIV counseling and testing linkage to care. So I come from that, and now I'm doing a different position, which is working within, still at the same university, but I'm working with the perinatal infected kids, and it'd be perinatal infected kids. So it's still the same thing, but it's just a whole lot more.
So Gina, I really want to thank you for your contribution and your enthusiasm, because that's what it needs in the community to really address some of the challenges that women experience, especially African-American and Latina women who come to the table often with so many cultural barriers and other social barriers. So it's that kind of energy we need. It's also that kind of energy we need with community health workers. And we're a little over time, but what I did want to do was just ask Allison to kind of make her final comments just before I turn it over to Michael. Allison?
Oh, thanks. I just want to say that I hear you, and it would be great, and definitely our hope is that some of the work that we're doing on this initiative over the next few years will be a little bit helpful with the issues that you all are experiencing. You know, in my view, like getting people to try to organize and advocate for these social and economic needs is really important, and it is a constant struggle because of the resources and the time that's required, and sometimes people don't even feel like they can make a difference. But if you know, encourage you guys to keep the faith and keep doing the great work out there, and it was a pleasure to be on the line with you guys today.
Thank you, Allison. Michael?
Absolutely. Thank you so much, Allison, for sharing your experience and for sharing info on your program. We have some excellent notes here on our whiteboards to share with everyone later today. And thank you so much, Dolores, for facilitating today's call. You know, we heard a lot of great stuff from a lot of wonderful women from across our country, and, you know, I'm excited to see, you know, how we can continue working together and building off of each other's progress to see what we can do to really drive home positive change and to achieve health equity. I just want to point out, Robert Bobo did make a great comment in the chat room as well, that folks should be trying to participate as much as possible in the unmet need and needs assessment process that Part A's go through, and I believe Part B's go through for their comprehensive plan every so often as well. So for those consumers on the line, you know, like Gina, who are interested in getting more and more involved, make sure you ask about these needs assessments and comprehensive plans, because this is going to be a great opportunity for you to try to inject some of that voice in the process. You know, as a person living with HIV myself, I totally understand and acknowledge and have felt the frustration that folks have said here that, you know, we're doing great work together, but, you know, if people don't come to meetings, then it's really hard to actually get things going. So again, from the National Quality Center, thank you everyone for joining us today. The call has been recorded. By the end of the day today, you'll receive an email from me that includes the recording and also the chat transcript with all of our great notes from the whiteboard. Thanks so much for joining us, and have a wonderful day, and we'll chat again soon.
Thank you.
Thank you. Have a good day.
Thank you.
Thanks, everyone.
Thank you.
Yeah, that was pretty interesting. What? Were you on with the African-American women and
the office hours?
Yeah.
Yeah. You were on it too?
Yeah, I was on it. Okay. I kind of felt like I've been trying to do them as much as I, you know. When I put them in my phone, and then they'll come up and say, but I was in the middle of doing something, so I had to wait to join, and I couldn't get onto the computer. It wouldn't let me join on my computer, so I had to join here.
Oh, okay.
So I'm kind of surprised that they're surprised that undocumented people can't drive. You don't have any documents. I mean, just, you know, I almost started saying, come on, people. They're undocumented.
Yeah.
There's no documents to prove that how. I mean, all over. It's not just in some states. It's all over. I'm like, are you kidding me?
So many people in the country who don't want undocumented people to be able to do anything.
Right. So now
I want them to be able to be arrested and deported. So why wouldn't you create the opportunity to arrest them but not let them get a driver's license?
Yeah, they can't. No matter where they go, they can't get a driver's license. But there are some places that I know what they're doing is some of the clinics, and this is more like they said, North Carolina, South Carolina, and this is like for people who really live out in the country. They have drivers that are volunteers,